Okay. We're going to addiction outpatient treatment, and I'm going to talk about the seeking safety model, and a model that a colleague of mine, Tanya Clark, and I created out of that model. So basically, we're in outpatient. We have a variety of people coming with a variety of issues, obviously with substance abuse, and the trauma has been my focus for quite a number of years. So the model, as I've got stuff on the table in the back corner there, was developed by Lisa Najowitz. It's a treatment model for the first of 3 stages, general stages in recovery from trauma, the first being safety. And what we found was that I did some work at the Sexual Assault Center years ago. I worked there, and what I found when I was at the Sexual Assault Center that was difficult for me was trying to get some traction with people with addiction that came in, and I was really confused at the time and didn't understand it. So eventually I ended up working over in mental health and substance use. And while I was there, the Sexual Assault Center was very progressive. They started to do a seeking safety model. I went, darn, I should stay. So anyway, I went back. Basically, the next natural step was that I started to collaborate with them. And we ran for a number of years. I worked with Linda Jennings and then a number of other people trained there. And we ran the seeking safety model. And the whole point of the model is to help people understand and make the connection between their substance use and their trauma. And part of the whole point of that is they're going to have to really watch it for time, I can tell. So part of the reason we do that is because there is a really high percentage, and it's the more they research it, the higher they realize it is between trauma and addictions. And so the actual task group that we started, the seeking safety model had an information part right at the beginning, and then the latter part, it could be 12 to 16 stages when I did it with Linda. And she modified a lot of the stuff, and Lisa Najowicz's stuff is great. However, you have to modify it for your own group, and there were some things that were a little too intense. And as an outpatient clinic, we have to be careful because our clients come and go home. And we have to make sure they're safe when they leave, or try to. So at Addiction Outpatient, we do a lot of one-to-one. We do a lot more of groups, psychoed groups. And the 2 that are particular to trauma in ours is the task, and it stands for Trauma and Addiction Skills and Knowledge. And then that is the psychoed group that is a lot about what Diane was talking about, of not rushing people, but giving them some information. So we incorporate a variety of tasks in the task group, and we use mindfulness and somatic approaches. And the goal overall is to make them have the connection about why they're using, not in terms of talking about their trauma. We do not talk about their trauma there, we make that clear. But why they're using, and they can normalize their experience. And this really helps in reducing their shame, which to me is huge, because they come in there with a lot of shame for themselves and other people in the world. So we normalize their experience, not saying it's right or wrong, right, but we say that it's normal to have this kind of a reaction to a traumatic event. And then we teach them the coping skills so that they can feel safe and feel less helpless, because those are part of the situation. So staying safe is important, and we treat them with the utmost respect and compassion to reduce the stigma and judgment they themselves have, as well as others. So it's really, really important how we do it, not just the content of the program. And I would like to, I think there's one in your handouts there about our trauma group at task. And it's 8 weeks, 2.5 hours a week, and it's that's a short period of time. But what we're doing really is just talking about learning about the connection and helping them develop skills to stay safe, as I said. And so if we say to them, if you have experienced trauma and are having problems with symptoms such as, and we go into the intrusive, the flashback, avoiding, difficulty sleeping, anger, etc., and substance use, the group might be few. And so then we give a group criteria to them, and they basically have to have experienced trauma, as outlined above, or in recovery, and have 1 month of abstinence from alcohol and other drugs. Now this is really hard from some of our clients, and so there's a concurrent issue going. We want to deal with things concurrently, but we really have learned over time to slow it down. And as I learned in Vancouver years ago in training, the slower you go, the faster you go when it comes to trauma. So rushing it doesn't work, and they have to decide for themselves when they're ready with our help. No active suicidal ideation, no dementia or significant cognitive challenges, no psychosis, no recent history of violence, aggression, or problematic sexualized behavior, and they have to participate in the group. Some of our clients aren't group appropriate. Really, already? 1 minute? Okay. And so a lot of times the support can come in one-to-one to get them ready. So people may come there and they will do some groups or some one-to-one. They might not be able to do groups, and eventually they may be ready and feel like they can go to task, which is a psychoed group only. And so we teach them basically how to manage their trauma and how to feel safe again for themselves. And we also have a therapy group called Full Circle, but it doesn't run that often depending on what our staffing is at the time. So who's in the community? They're here. The people that I saw, some friends I haven't seen in a long time. And I guess I just want to say that I think the most important thing, the whole most important thing with any of this work is to treat people with the utmost compassion and respect, because especially concurrent issues with substance use and trauma, they already feel really bad. So the essence is to empower them and to make themselves safe when they're overwhelmed, and that's about it. Oh yeah, how much time do I have? None? I'll have the information back there. I can talk to you about referral through our intake, and that's it.
Thanks, Joe.
I want to go as quickly as I can. So ICA has been around in this community for 45 years. We started in 1975 working with refugees with the Indo-Chinese boat people movement, as how many people refer to it. At that time we served only refugees. Over the years the group of immigrants that we served expanded to include all of the classes of immigrants. And in Victoria, we've had relatively low numbers of refugees over the years, and I wanted to just speak with you tonight about refugees. So in recent, in the last 6 months, we've had two developments. One, we became a sponsorship agreement holder, so we can work with constituent groups in the community to sponsor refugees to come to Canada. And we were approved again to do work we used to do but haven't done in about 25 years, to bring government-sponsored refugees to Victoria through the RAP program. Now, at the moment, most of those refugees that are coming are from Syria, and they're arriving, started arriving mid-December, and will continue, and the numbers will grow. So I bring that up because some of you will see them. Before I talk more about the services we offer, I'll take advantage of this moment to say, if you are working with newcomers, particularly refugees, you should familiarize yourself with the Interim Federal Health Program, which is the program that allows those people to access services prior to getting on to BC Medical. So in that interim period, that's why it's called interim, when they first arrive. And you register through Citizenship and Immigration Canada's website. It has not changed the name of the website to the new name of the ministry, which is Immigration, Refugees and Citizenship Canada, IRCC. So, to speak to that, IRCC funds most of the programs that we offer. Our staff is about 85 people at the moment, so we're a reasonably large organization. We do this full spectrum of settlement services. So when people come in with the refugees, we pick them up at the airport, we take them to temporary accommodation, we provide them with orientation to the support program that they're going into, or work with introducing them to the groups that are sponsoring them in the community and support those groups. We then, we do a full needs assessment when people come in through what we call our settlement department. It's not like legal settlement, it's like resettlement in a new country. And that really looks at anything people might be needing, whether it's financial need, whether there's health issues. Our workers are lay workers, lay counselors, even though they're often called settlement counselors. They're not, they're lay counselors. But they work often and connect people to other counselors in the community. A lot of the work that's done in the settlement program and in other programs that we run is around creating a sense of normalcy, normalizing the experience that people are going through. We know that when immigrants and refugees, it can be more acute in certain groups than others because of their background and what they're coming through, that people generally come in on kind of a high, and as they realize how tough it is to learn the language, to get a job, to be recognized, to be able to even express themselves in minimum ways, to handle the school system, their state tends to go down quite rapidly. And then over time it will sort of go up and down and then stabilize. And for the most part people do okay. But it can be quite a long road, and it's not quick. People are often very stunned to discover that it takes more than 6 months to learn English really well. It doesn't. For an adult it's more like 3 years, so realistic expectations are a lot of what we deal with, guys. And so we provide ESL classes, which are half language pretty much and half Canadian cultural, how to navigate the culture that we run. We run employment programs. We run a lot of groups for children, youth, adults, women, men, to try and get people to talk about some of the things that they're challenged with. And it really is about creating a safe environment, but it is not therapy. I think I'll end it there. Thank you.
You're my timekeeper?
Yep.
Okay. So I'm really glad to be here. It was supposed to be Paula Green, our executive director, but she fell sick, and this afternoon she volunteered me, so this is off the cuff. We're a small nonprofit. We've been in existence since 2003 in Victoria. We currently see probably 250 new clients a year that come to our office. We work solely with men who have experienced trauma, but we also do talk to partners, mums, sisters, aunts, other support people who likely have encouraged them to come and see us. So it's not exclusively men, and we're not exclusively men, obviously, in the office. Men from 16 and up officially, but we've had a 15-year-old or two, all the way up to men in their 80s have come to us, but mostly we see men that are between 30 and 45. That seems to be the time when they make the decision to come forward and get some help. So my role as Victim Services Coordinator with my job share partner, Sue, we provide the intakes. We're probably the first person that the new client is going to see. And the difference with men who've experienced trauma compared to women is that they probably haven't talked about this forever. And when it gets bad enough to come and talk about it, there's a backlog of layers of trauma that they now begin to deal with. So we don't know when they come in if this is something recent, or whether there's going to be a whole eruption of different issues that come out that they want to talk about. So this is what we're doing in the intake, is sorting that out and figuring out whether we're going to work with them as a victim services coordinator, ongoing, providing emotional support, information, referral, some help. If they want to report something to the police, we can provide that support. And they may want to do some trauma therapy, so work with one of our trauma therapists doing one-on-one counseling, or attend one of the groups. We've got a very successful group for survivors of trauma, and the data that's been taken at the beginning and the end is showing that it is decreasing the PTSD symptoms. And we now have funding to do a second stage group because those guys are really keen to do something more. So people find us just by walking past and seeing the sign. They come in. We receive referrals from physicians, from mental health workers, from addictions workers. There's no onerous intake or referral process. People just have to contact us, and we will see the guys as quickly as we can, because we know very often that moment can be missed. That's the day they want to talk about stuff, so we really try and see them as quickly as we can so we don't miss that moment. There are some significant differences in the ways men cope with trauma compared to women. There's a lot of similarities, but men have been socialized to suck it up, and they do that well, and they do it to their own detriment. So as I was saying, often there are layers and layers of trauma that have been accumulating since childhood. And it is quite shocking sometimes, the amount of pain that these men have suffered as children. It often starts very early, and it is, sexual abuse, emotional abuse, physical abuse, but what stays, what lingers, is the emotional component of that abuse. Got the 1 minute sign there. So I have some information at the table. If you have questions, happy to answer those questions. Because we're a nonprofit, we're not encumbered by a big bureaucracy, so we're very approachable. The flip side of that is, we're underfunded, but we make sure that we see everybody, we don't turn anybody away. The Victim Services Program is a free service, and it's amazing how long some people will stick with us. I see some guys that I first saw when we first opened, some that I saw 10 years ago, and they'll periodically come back and sort of get a booster shot to get them through the next part of their lives. So we've proved that it works. We're passionate about what we do, so I hope to get referrals.
So I'm actually going to start with how you actually refer a patient to us. So our crisis and information line is the 3232 number. It's not up there, but it's on all of our literature. It's actually front and center of all of our literature. We pick up that number in the office Monday to Friday, 9:30 till about 4:30. Half the time it's usually me, just so you know who you're talking to. We actually prefer you to tell the client or patient, to contact us directly. That is our preferred method of referral. You're welcome to call and ask any information at any point in time, but we prefer the client to actually make that first step in their healing journey by themselves. One of the things, we have several different types of program at the Sexual Assault Center. We have a crisis program, which is either for recent sexual assaults, or if it's past sexual violence where the survivor is having a lot of difficulty coping on a day-to-day basis, they can access a few sessions through that crisis and stabilization program. Beyond that, we do, and that's more stage one, really skill building, working on their coping skills, just really building up their resiliency and dealing with immediate impact response that you've been hearing tonight. In terms of our more therapeutic stream of counseling, we really try and slow down that process quite a bit. So the first step would be we would send them to an information meeting so they could get a chance to get a feel for who we are and what we do and make a choice as to whether they want to access services as they go forward. When they have decided to do that, they would most likely be referred into a skills group. That's a very short-term group, really focused on developing the coping skills needed to go forward in their healing process. If groups are not appropriate, we can actually offer that information on an individual basis. So whether that's shift schedule or whether they're just not group appropriate for whatever reason, we do have that option available. Once they've completed our 2 basic groups, we can look at doing our individual trauma therapy, and that we have very skilled counselors on staff who've got many, many years of experience working with trauma. And we have some who are specializing with EMDR and others who use somatic in their practice. So, and many other groups beyond that. We also, as with the Men's Trauma Center, are a specialized victim service program. So we provide pre-contemplative police report to post-correction support for survivors of sexual violence. Our counseling programs and our victim service programs are open to women and people who are trans-identified. We have some other programs that are available that are a little bit more open. So we actually have a sexual assault response team and have had for many years in Victoria, primarily working out of Victoria General Hospital with forensic nurse examiners, police as required, and support workers. We've recently opened up a sexual assault clinic, and it is absolutely brand spanking new. So there is some information in your literature on how to access that clinic. The clinic is to move that sexual assault response out of the hospital setting and into a very low barrier access for that person. That program is available for any gender, ages 13 and up. Our crisis and information line is also is the best way to access that team. We also have some youth prevention programs available. And what I would really like to encourage you is, when you're taking a history from your patient and they identify sexual violence in their background, it's not an automatic referral to either men's trauma or the sexual assault center. You have to really ask the survivor whether this is something that they want to open up at this point in time, because it's not always the perfect time. So thank you very much, and come in and talk to us on at the table.
Great, thank you.
Well, I'm really glad that got that up, because I just found out today I was coming. Anyway, really nice to be here. And I really enjoyed what went before, because I think one of the things I want to talk about, not only our service, but who. I think it's really important for you to know that our agency serves children. I would say we could talk about 1 and up. We're not going to be doing counseling, obviously, with a 1-year-old, but we're probably doing a lot to support the parents of that child. One of the things you heard in the earlier part, and we didn't really talk about, is attachment. We talked about those little rats that lick. And one of the things we know in trauma, that if you don't have a lot of support, or if your caregiver has a traumatic event going on for themselves, or many adverse experience going on in their life, it may be very difficult for them to give the support to the children that they need. So when we see a child, and a child is referred to our agent, they often don't get a choice. Unlike an adult who might say, oh, I want to do counseling. They're often going to be referred either through our victim service program, which does intake as well. Those children actually may be children where disclosure has occurred, a police interview is going to occur. Along with Sexual Assault Center, we now have a child advocacy center that's just new and opened up in the last 2 weeks. And we are really hoping that children no longer have to go to a police station to do an interview along with our victim service support. But our victim service support worker will be right there at the time of the interview to support the child and the family. And we know the really good prognosis. If we support the family caregiver, and if they can stay calm, they can really help the child to get through it. Some children may not go on to be identified and actually have a PTSD response. I think there was a bit of a mention about PTSD developing perhaps later on. Many of the children we see actually have, I don't know if you've heard of the ACE study out of the US. It's done a while back. It's the adverse events for children, and it's really looking at the number of incidents that later on children would go on to develop mental health difficulties. And so we're actually seeing many children who are coming through our agency. They come through the Sexual Abuse Intervention Program. That is the funded program out of the BC government, and they're all around the province. So that is an identified group we've seen. But I've been with the agency 25 years now, and we've seen over time that there are many children coming in with multiple forms of trauma. And so we have gone about trying to create funding for, especially for children who have witnessed violence and abuse on an ongoing, may have their own experience of abuse as well. The effects of that are pretty astounding. Some of you may have heard of Vanderkolk, who's looking at a new developmental trauma diagnosis for those children who have a whole dysregulation pattern. So I think it's really important. What I'm trying to suggest is that we want to see the child as early on as we can. One of the difficulties we often have is with timing, that we don't have enough front-end people for the number of children who need service or for the time they need it. But that's not to stop you from referring. If you are hearing, if you have a disclosure, making sure the proper authorities know about it, but also ensuring that there could be a referral. If they're doing really well and they're stabilized and they don't need anything, that's the end. We don't have to do that, but our victim service can actually give support to the family and the caregiver. So our program for victim service, if a child or youth has to go through court, our victim service worker will actually meet with them many sessions to prepare them what it means to go to court, do court accompaniment with them, go to the interviews with them with Crown, and actually we have sat in the stand with the child if need be. or we make sure that there are accommodations for them for CCTV, which means the child doesn't have to be in the room. And the counseling end is the mainstay of what we do. So we might have groups if we have enough people who are, I guess we'd call teens maybe in a particular age group, particular issues. We have one going right now for teens 16 and up. We are running 2 parent support groups right now, and 10, 11 in each of those groups. And most of it then is individual counseling with thorough assessment, figuring out, we do a PTSD checklist to see what we're dealing with. What wasn't mentioned is often that children turn up very differently when they have trauma symptoms. And it may not look at all like you'd suspect when you see an adult. One thing to remember, I mean, although they have some criteria for it, is harder to notice. But we've had severe things where children have disrupted whole classrooms, and we've had 6-year-olds kicked out of school because their behavior is not able to be dealt with in the school system. So it's all about support, getting the parents in to support the children. The information is all in your pamphlet, how to get access us, the referral for both the CAC and or for the agency. So thank you.
Good evening. Thank you so much for having us all here. It's been great to hear from the other agencies and such an interesting presentation. Lest you think that you're drinking from a fire hose, I'll try to just tell you a little bit about our organization. We are the Military Family Resource Center, and it's really important for everyone to know that we are a small, not-for-profit organization. Oftentimes there is the assumption that we are a large government-funded agency, and we're not. We are partners with the military base. We are accountable to all of the families and the military members, but we are very much a separate entity that's covered by a privacy code and holds the highest in confidentiality. As a result of that, very often we're the first people that a military member and their family will come to in a time of crisis, and certainly in a time of trauma. And our job is to work with them to help walk them back to the system and to try to help them navigate their way through. It's really a system that was built about 30 years ago now from a grassroots movement that was sort of created by families who said that, you know, this is a tough lifestyle and we think we need to have some help and support doing that. A few years ago, the Canadian Armed Forces Ombudsman wrote a report called On the Home Front, and it's a report about the military family lifestyle. It identified for us, it created some great language, sort of the 3 main elements of what it means to be part of a military family. And that is that our military families deal with and are exposed to relocation, deployment, which means separations that could be anywhere from a few weeks to sometimes a year. We have a ship that's just returned from 9 months of being at sea. I'm sure you can imagine the family life that unfolds while people are away. And the third part, if you're thinking about a Venn diagram, is the exposure to risk or the threat of risk, and that's our social and mental wellness piece. And a lot of military members and families are in the very center of that, having those weather systems swirl around them. So part of what we do is help to connect them with programs and services and information, and really most importantly, the ability to network and to learn from one another. We have many resilient families who are very helpful in that matter. Specifically, I'd like to tell you about a project that we've just begun with Veterans Affairs, and what we're doing is we're working with medically releasing veterans and their families for 2 years post-release. And the idea behind this program is that is a very, very difficult transition. In general, it's very hard to transition from a lifestyle like the military lifestyle. But when someone's being medically released due to any kind of a diagnosis, but a great deal of a post-traumatic stress disorder, it's a really, really very challenging time. And so what we'll be doing is working alongside Veterans Affairs and walking with the family and with the military member with the idea that after 2 years they will have made a successful transition into what we call civilian life. A big part of that, of course, for the veterans and their families is finding appropriate medical care and finding all of the appropriate resources that they need. So part of what we do is help people navigate those systems, whether it's the healthcare system, whether it's the system of community agencies that we're so richly blessed with in this community. And it's a way of helping people connect outside of that military culture. There's a little bit more information about that in your folders, and so this is just to let you know, because I'm sure that in your practice and in your dealings you will have people who are medically releasing and who have an array of very, very specific needs. Also, I'm sure that you have many people in your practice that are military families. So this is a way of letting you know that we're here. Please contact us. We have professional social work services. We have networking programs and educational programs and prevention and support. And that's what we do for a living. We work with the over 5,000 military families that live in this community. So thanks for your attention.
Thank you.
Thank you.